All right, let's start. For those of you who are new, my name is Sandeep Bana. I'm an endocrinologist. And on behalf of ME Screening, which is a company that does mitochondrial testing based in the USA, we're running a training and certification program so that you as the audience can better use this test, assist it to help your clients. And Leonie's just sending me a message, 1 second. So 2 nights ago, I was involved in the launch of Vigovi, which is Vigovi is a weight loss GLP high dose Ozempic product, and there were about 800 people. And tonight we are competing against the second launch, and they're expecting about 800 people today. For those of you who are involved in weight loss management, I think next week, Tuesday and Thursday, there are 2 more online presentations. And then there's the one that is live on the 16th in Cape Town. So that's what we're competing against today, unfortunately. So mitochondrial training and certification, there were 4 modules. About 2 weeks ago, we handled module 1, which showed how mitochondria work and the relevance to health, wellness, and disease. Module 2, we covered the basic physiology and biochemistry of mitochondria. And today we're going to be tackling how practitioners are testing mitochondrial function. So at this point in time, what's available out there. And I'm going to try and frame this particular test. And then the 4th one's very short in terms of how you as a practitioner can explain to your clients what MeScreen does and how it's going to assist your clients. So let's just recap a bit in terms of what we covered. Module 1, we looked at the mitochondria and the role in health, wellness, and longevity. We tried to cover these learning objects. It was to review the role of the mitochondria in the human body, understand the basic structure of the mitochondria, describe how mitochondria are linked to health and disease. And so this was the summary slide of module 1. We said that the mitochondria do more than just produce energy. It's impacted by inherited internal and external factors, plays a role in the aging process. It's an integral component of cell signaling and survival, and it's located in every organ system. So it goes beyond just energy. So that was module 1. Module 2, we went through the biochemistry and physiology, and here our objectives was to look at physiological and biochemical processes that are associated with the mitochondria, understanding the physiological processes associated with the core biochemical processes, and then compare physiological and biochemical processes that are happening within the mitochondria. This was a summary slide, so I'm just going to go through it for those of you who missed the first one. Biochemical processes within the mitochondria play a critical role in maintaining energy production, cellular homeostasis, and regulating ROS, which is reactive oxygen species, and supporting various metabolic pathways. The moving of electrons efficiently along the electron transfer chain is critical, and when degradation occurs, mitochondrial dysfunction is the result. Primary and secondary diseases cause degradation along different parts of the electron transfer chain, and understanding with specificity where the degradations are occurring and the resulting impact on the biomarkers. And this will help facilitate decision making. Biomarkers are associated with mitochondrial biochemistry that are impacted by toxic stresses, normal day-to-day influences, and basically we looked at single marker tests that would be diagnostic for mitochondrial dysfunction or diseases, because typically we were using just genetic testing, and historically we only thought of mitochondriopathies as primary genetic conditions. So now let's go on to module 3, how practitioners are testing mitochondrial function. So what's happening now? We're going to try and uncover these objectives to understand the routine testing methods used in assessing mitochondrial function. We're going to differentiate biomarkers, genetic markers, and functional testing. We're going to review the benefits and limitations of each one of these 3 tests, understand functional testing methods, and the measures that they can report. So I told you guys for the first presentation, module 1 and 2, these are not my slides, so they're quite wordy. And in the States, some of the doctors will self-study to achieve CPD points. But here in South Africa, we're just going through it together. And I'm sure at some point the company will make this available online for training purposes. So testing for mitochondrial function. The Mitochondrial Medicine Society has published consensus statements on the diagnosis, management, treatment, and care standards for mitochondrial diseases. They recommend biopsying the affected tissue to assess mitochondrial DNA variants, and we covered this extensively in the first 2 modules, the oxidative phosphorylation function. The problem is, not all tissues can be biopsied. Typically, it will be the muscle. But I also mentioned that the way this field is heading is that mitochondrial function in the heart may vary to the liver, to the brain, to the adrenal gland, to the thyroid. And so a muscle biopsy is not going to be telling you too much about some of the other organs. Although mitochondrial dysfunction is known as a primary mitochondrial disease, it is secondary to many multifactorial chronic conditions. It is often difficult to measure and prove, especially when biopsies of affected tissues are not readily available. So there are 3 classes of testing. Functional markers, which are measured in blood cells and living cells. You get the biochemical markers that can be tested in serum plasma, and then you got DNA markers. While none of the reviewed single biomarkers may perfectly reveal all underlying mitochondrial dysfunction, combining these biomarkers that cover different aspects of the mitochondria will give us a good strategy. So now let's look at what's been historically available from a genetic perspective, and then look at the role of epigenetic testing as well. So genetic testing has become big. My primary degree was actually in BSc, with my majors being in genetics and physiology. So that's where my interest started before I got into medicine. And we've come a long way from when I did genetics. So genetic testing, we thought at the time, was going to be able to help us with every medical condition. But now we understand that genetic tests examine your DNA to a pinpoint change. They look at mutations or variants, which can significantly inform and alter your medical care. This type of testing is foundational in identifying genetic conditions and tailoring healthcare to individual genetic profiles. So genetic tests identify the potential of something that may or may not happen. And that's the thing. So 40 years ago, when I was studying this stuff, 44 to be exact, from that perspective, we thought genetics was going to be the be-all and end-all. But all it tells us is that if you've got the BRCA gene, you've got the potential of breast cancer. It doesn't mean you've got it. And it may or may not happen in this lifetime. So it's important, but doesn't speak to the full issue. What are the different types of genetic testing? So the single gene test, this method focuses on one gene to detect specific conditions If symptoms of a known disorder like Duchenne muscular dystrophy are present, or there's a family history of this genetic mutation, then this test is often recommended, because if one family member's got Duchenne muscular dystrophy, then the potential for others will be there as well. And then depending on whether the condition is autosomal dominant or recessive or sex-linked, it then predicts who's likely to get it, and then you identify it, so then you can expect those medical conditions to present themselves at some point in the future. This is single test. Panel testing, oh, I see they've cut and pasted this by mistake. So panel testing is when you're looking at a series of gene tests in conditions like epilepsy, where there might be certain medical conditions with epilepsy that can affect and present themselves in multiple clinical ways. So here we're looking at more than one test. And then you get large-scale genetic testing, including exome sequencing, which examines all genes and genome sequencing and reviews the entire DNA. These tests are utilized for individuals with complex health issues, offering uncovering some primary genetic information, but also secondary findings that will affect and influence management. And so those are the three different types of testing. Let's look at the application of these genetic tests. So genetic tests serve multiple critical functions in healthcare. It is used to diagnose inherited conditions, assess risk levels for future health issues, and guide treatment plans. And so for a long time, people that have been involved in managing mitochondriopathies, they were mainly primary. So we knew, okay, this person's got, from a biopsy, they've got primary mitochondriopathies, and this is what we're expecting them to have going forward. By understanding a patient's genetic makeup, healthcare providers can predict potential health challenges that are going to come, and if possible, in some conditions it's possible, others it's not, we can start intervening early. Genetic tests which identify specific DNA mutations are highly accurate in detecting those genetic variants they are designed to find. So you can set out probes to go and look for specific genes, and then you can identify them, and it gives you a predictive edge in terms of what's going to happen in the future. Now, I think these single gene tests do make a comeback, because when you've got CRISPR technology in the future, conditions with single gene defects can be targeted, and basically using a bacteriophage, each one of those DNA strands in every one of your cells can basically be edited out and removed. So these tools are going to still remain important. The precision of these tests is largely dependent on technology used, and you're getting newer and newer technology. So the next generation sequencing, which boasts the highest degree of specificity and sensitivity. And so these are available to us. What about epigenetic tests? Epigenetic tests explore how external factors like diet, lifestyle, and environment can alter the way genes express themselves without changing the underlying DNA sequence. So unlike genetic mutations detected in standard genetic tests, epigenetic changes are typically reversible and can switch on and off genes, which can significantly influence health, disease potential, and outcome. So genetics tell you you've got the potential of developing, let's say, Duchenne muscular dystrophy, and if these things happen in your lifestyle, stresses, exposure to chemicals, then the condition's going to express itself earlier and maybe with more severity. I'm just using Duchenne as an example, but it may not apply here. But there's many other conditions where epigenetics determines how bad the condition is going to be. So what are the different types of epigenetic tests? You may have heard of methylation, histones, RNAs. Let's go through them. So the DNA methylation tests, these tests identify the addition or removal of certain chemical groups to DNA, which can then inhibit or facilitate gene expression. So if a gene is there on your DNA and it can potentially do something, it doesn't mean it has to do it. And if it wants to do it, it can do it for certain parts of your life, and it can switch off other parts of the life as well. So it can awake, it can go to sleep, and gene expression can change based on methylation. So methylation patterns are crucial for understanding various conditions and how external factors may suppress or activate certain genes. Histone modification tests. I remember when I studied this, histones was huge, right? And histones are things that DNA wrap themselves around, and by examining changes to histones, proteins around which DNA wrap, so by examining changes to histones, these tests can reveal how tightly DNA is packaged. And if DNA is tightly wrapped, the gene cannot express itself or will express itself at a lower rate. Where once it's loose, the expression is freed. And so once it's tightly packed to histones, the RNA can't come, split the DNA, read it, and go and make protein molecules. That's basically what that is. What about non-coding RNA tests? These tests focus on RNA molecules that do not code for protein but play a critical role in regulating gene expression. They help in understanding how genes are controlled at a transcriptional level. So you can see that there's a strong interplay between DNA, protein, non-coding RNA, coding RNA, and I mentioned in the module, in the second module, endoplasmic reticulum as well. So this is crucial. What are the applications of epigenetic tests? So epigenetic testing is utilized in various medical and scientific fields to understand better and treat conditions that are influenced by gene expression. These tests are pivotal for researching developmental diseases, behavioral disorders, and other conditions where gene expression changes are significant. So from that perspective, this can change. You may be well now, but that condition can change, and the expression can increase in time. So from a developmental perspective, neurocognitive function, muscular development function, this becomes important. Under what condition is epigenetic testing helpful? Epigenetic testing shows promise in behavioral disorders. Certain epigenetic changes in gene expression related to neural activity that influence behavior and susceptibility to these disorders. Parkinson's, dementia, neurodegenerative disorders. You're going to see ADHD, people on the spectrum. Epigenetics is going to play an important role there. Epigenetic modifications can also indicate responses to environmental stresses or dietary changes, which are essential in managing diabetes and cardiovascular disease. So type 2 diabetes is a disease of low-grade inflammation, of insulin resistance and glucose toxicity, and basically dense cholesterol particles. Now that is toxic to the environment, and toxicity begets toxicity. And obviously it's going to affect how the mitochondria are going to act in various tissues, and that's what we talk about epigenetic modification, where this condition through epigenetics affect mitochondria, and then once the mitochondria is affected, the diabetes is going to worsen. Same thing with cardiovascular disease. Epigenetic testing offers a dynamic perspective on how genes are regulated and interact with our environment, providing a deeper understanding of numerous diseases and conditions beyond what genetic tests can reveal. This understanding will aid clinicians in devising more targeted, effective interventions. And so genetic testing is important, but I would argue epigenetics is now even more important from a clinical perspective. So this table has a comparison of the two. So let's look at what genetic testing does What it measures is DNA sequencing mutation and variation. What is epigenetics measuring? Modification in gene expression, not just the DNA sequence itself. What's genetic testing focusing on? Identifying inherited risk and genetic mutations. That's important. I would like to know. So if you had GPD6 deficiency, or if you had cystic fibrosis in the family, you'd like to know, this is important, whether you at risk, you 1 in 500 individuals that have that risk. Whereas epigenetics will look at how environmental and lifestyle factors will affect that gene expression. What are the technologies used? Here we use the old-fashioned PCR, microarrays, next-generation sequencing to uncode the genetics, whereas epigenetics uses bisulfite sequencing, chromatin immunoprecipitation, followed by sequencing. What kind of information we get? With genetics, it's static. It provides a long-term view in terms of what is potential. This is dynamic and changes with lifestyle, environment, and over time. The impact of disease understanding. So genetic testing is essential for diagnosing inherited conditions, carrier screening for the next generation, and risk assessment. Whereas epigenetic is useful for understanding how non-genetic factors influences the disease, progression, and treatment response. Clinical applications, predictive risk assessment, carrier testing, and prenatal screening. In terms of epigenetics, monitoring of disease progression, evaluating treatment response, and lifestyle important. So I asked ChatGPT to take those two tables and give me an example so that I can better explain to a medical audience how these two fit in. So I'm not taking credit for this one. So if you test for BCRA 1 or 2 mutations, this is basically testing for hereditary breast or ovarian cancer syndromes. So that's a condition. That's what genetics will tell you. You go for a blood test, and for instance, that's my sister goes for it. She turns positive on one of this. So it tells her she's got a potential for one of these two. So it detects the presence of a mutation. What's its clinical relevance? A patient with this gene mutation has a significant increased lifetime risk of breast and ovarian cancer compared to somebody who doesn't have it. And so it might help strategize in terms of how often she goes for mammogram, does she prophylactically remove her breasts? And so it's basically about screening protocols and potential treatment to mitigate that potential of having breast cancer. So it threw out an example for epigenetics, MGMT promoter methylation testing in glioblastoma. Glioblastoma is a brain tumor, and so here it detects methylation status of the MGMT gene promoter, which regulates DNA repair. So what's the clinical relevance here? Methylation of this MGMT promoter silences the gene expression, making the tumor more responsive to chemotherapy. So the client's got the tumor, but by looking at epigenetics, you can say, depending on whether the gene is switched on or off, this patient is going to be responsive to the chemotherapy or not. And so that way you don't have to waste your time in continuing. You may want to change your strategy. So that's the difference between genetics, which is potential, but you may never get it, whereas epigenetics, you've got something, and how do you now, because it's going to keep changing, and how do you basically unwind your treatment? Now let's look at some biochemical markers. So we went through genetics now. Now let's look at biochemical markers. So metabolic screening studies in blood and urine are useful in determining whether an individual with suspected primary or secondary dysfunction of the mitochondria. What are the common markers? So you can look at chemistry panels, FBC, with the differential, blood lactate and pyruvate levels, ammonia levels, creatinine kinase, H1C, plasma amino acid analysis, carnitine, acyl carnitine profile, the lipoproteins, hormone screening, urine tests, looking at urine organic acid analysis and amino acid. So there's a lot to assess here, right? But we must be cautious when interpreting these results, as any alteration identified will not be specific to mitochondrial disease, because it can also relate to how the test was done, and that's what I'm going to show you now. So what are some of these tests in blood or urine? So organic acid testing. This is an option for assessing mitochondrial function. This evaluates the metabolites from digestion, assimilation, metabolism, and production of ATP. The preferred specimen is urine. These metabolites are more easily extracted from urine than plasma. What are the metabolites they're looking at? Ethyl malonate, epidate, suburate. These reflect beta cell oxidation. If you look at L-carnitine, this is necessary for carrying long-chain fatty acids across mitochondrial membrane. So if L-carnitine levels are inadequate, beta oxidation might alternatively take place in the peroxisome, creating elevated levels of epidate and sucrate. So when you got too much of this, it's telling us that ATP production is not happening here, but happening in the peroxisome. Ethyl malonate is a breakdown product of butyrate, and it's also dependent on L-carnitine. So basically, you're looking at different metabolites and then indirectly making assumptions in terms of where there's a leak in the pathway. If you look at succinate, fumarate, and malate, they may indicate inefficient energy production, as they are part of mitochondrial oxidation. Markers indicative of carbohydrate metabolism would be pyruvate, lactate, beta-hydroxybutyrate. Metabolites of the citric acid cycle, which we covered on module 1, some of which were mentioned previously and can also indicate variation in energy production. So that's organic testing, basically looking at metabolites, preferably in the urine, and it gives you an idea in terms of anaerobic, aerobic energy production. What about amino acid testing? Amino acid quantification can be performed on blood. For example, elevated alanine levels may be a useful marker for long-standing pyruvate accumulation. Other amino acids whose elevations have also been associated with mitochondrial dysfunction will be proline, glycine, and sarcosine. So it's important to remember that these tests are not diagnostic, but can guide treatment options and evaluate progress. They again provide potential for something that may or may not be, and that's the thing. It doesn't mean if a test is positive that something is happening. So what are the limitations of biomarkers? Patients with mitochondrial disease may have normal lactate and pyruvate levels except when undergoing metabolic crisis or following exercise. So you can't always assume that a patient with a mitochondriopathy is or are going to have high lactate or pyruvate levels. Many patients with mitochondrial disease consistently have normal or minimally elevated lactic acid levels. Of course, when it's high, it tells you you probably have it, but again, it's just not a probability. And if it's not there, it doesn't mean you don't have it. Elevated levels of plasma lactate or pyruvate levels may be seen in a range of other primary mitochondrial diseases. Spurious elevations may also seen with poor collection, handling technique. Physiological elevations can result in secondary mitochondrial dysfunction. And that can be caused by many things. We've said the metabolic syndrome, diabetes, cardiovascular disease, neurodegenerative disease, nutritional issues. Pyruvate is quite unstable. necessitating blood specimens to be immediately transferred within 30 seconds after drawing into an 8% perchlorate on ice and analyzed as quickly as possible. And then depending on the handling, pyruvate levels may increase or decrease and are elevated in immediate postprandial periods. So you can't do it within 2 hours of eating a meal. It needs to be done speedily by the labs, and how you handle the sample obviously affects the test results. Elevated alanine is a low sensitive marker, so not a very good one, and can change during physiological stress and regression. Amino acid tests results may indeed be affected by various conditions, including improper specimen handling, hemolysis, dietary intake, improperly stored specimens, especially when you're looking at glutamate, aspartate, ornithine, and with decreases in glutamine, cysteine, asparagine, and homocysteine. So you can test for amino acids, but too many things affect it, and some things will go up and some things will go down, and that's why it's a variable response. Carnitine testing is limited by false negatives in individuals with total carnitine deficiency. So if you've got low levels anyway, you're going to falsely pick up a level and then assume it's a active mitochondrial problem. And it can also be elevated in patients that are taking carnitine. And so a lot of bad tests, but these things all come with their own problems. What about functional testing as a diagnostic target? Since different forms of mitochondrial dysfunction may affect the brain, heart, peripheral nervous and endocrine systems, eyes, ears, gut, kidneys, among some of the organs I mentioned, mitochondriopathies have been proposed as an attractive diagnostic target to be investigated in any patient with unexplained progressive multi-system disorder. Generalized approaches such as physical exercise, which may demonstrate neuroprotective, cardioprotective, anti-cancer effects, are clearly associated with mitochondrial function. So, when you tell your client, please exercise, it will be good for the heart, or it will be good for your neurodegenerative condition, or it may be good for cancer, the positive effect is coming from physical activity, and the work is done through mitochondria. Function of the mitochondria can be changed by lifestyle and therapeutic interventions. So functional testing provides a mean to stratify and monitor progress. So you pick up a problem, you give a particular lifestyle prescription or therapeutic intervention, and then you've got a means of testing whether that has worked or not and making adjustments. Phytochemicals, naturally occurring compounds used due to their neuroprotective, cardioprotective, anti-carcinogenic effects have been demonstrated to modulate mitochondrial function. So a lot of the things we use from a natural compound perspective for these conditions are benefiting these conditions, again, because of the mitochondria. Recent progress in areas of mitochondriopathies reveal that patient stratification and risk assessment are supportive of effective treatments, considering the levels of mitochondrial impairment and individual predisposition to associated pathologies. So, mitochondria play a huge role in everything that we do on a day-to-day basis. So, let's look at some of the other ways of looking at mitochondrial function. Oxygen consumption rate, extracellular edification rate. The measurement of oxygen consumption rate and extracellular edification rate provide a system-level overview of cellular metabolic function. So you get a nice aerial view of what's happening. OCR is an indicator of mitochondrial respiration, whilst ECAR reflects glycolysis. These measurements are typically performed using a Seahorse XF analyzer, which allows real-time monitoring of cellular bioenergetics in living cells. This was published in Nature, and following that and these publications, the University of San Diego came up with the test that we're going to be talking about today, the ME screening. High resolution respirometry. So high resolution respirometry involves measuring oxygen consumption of isolated mitochondria or permeabilized cells using the Clark type oxygen electrode. This method provides detailed information on activity of the electron transport system and overall mitochondrial respiration. This was also published in Nature. And then with the use of fluorescent probes for membrane potential, if you recall, on the first one, I said the mitochondria, all the action is happening on the inner mitochondrial membrane. And so, and I said we create an efflux, right? Positive, negative flow and energy gradient. So fluorescent probes such as the tetramethylrhodamine, methyl ester, and JC1 tests are used to measure the mitochondrial membrane potential. These probes accumulate in the mitochondria in a potential-dependent manner, allowing the assessment of mitochondrial health and function. And this was published as well. So by utilizing these three tools, you can then assess the oxygen consumption rate, and you can look at when the mitochondria, so non-mitochondrial oxygen consumption, in terms of what the mitochondria is consuming during basal respiration, the amount that is leaked, we discussed the proton leak across a gradient, how much ATP is produced, what's the maximal respiration if you had to do a 100-meter sprint by like Usain Bolt, what's the potential, and then what's left. So this is looking at oxygen consumption rate, and this is looking at ECA over a period of time. And basically, this is the magic that happens in this test. But obviously, you don't have to understand this. You just get a report. And the report looks at the functional panel test. It looks at the non-mitochondrial respiration, basal respiration, proton leak, ATP-linked respiration, spare capacity, glycolysis, oxidative phosphorylation, metabolic potential, and ROS. So modern analytical instrumentations can measure oxygen consumption rate and extracellular acidification rate in living cells. The OCR and the ECA rates are key indicators of mitochondrial respiration and glycolysis. These measurements provide a system-level view of the metabolic function at a cellular level and what's happening with the physiological processes. Paired with other information, the ability to assess function provides a tool to identify with more specificity what is actually happening in the cell. So now let's summarize the three different ways. Genetic testing tells you what might happen. Only indicates likelihood of having or potentially getting a condition. The biomarker and enzyme and chemistry tests that go off in your urine and in your blood tells you what may be happening. It's not definitive, but potentially could be there. So blood and urine-based biomarkers have the limitation. There's a high interpersonal variability. Measures not directly correlated with specific dysfunction, like high lactate indicates that there may be dysfunction, but it may have just been measured after exercise. So here, let me put an analogy. So you've got a diabetic patient. They come to you with a DKA, coma. They recover from the coma. You tell them, listen, the reason why this is happening is that you haven't been controlling your diabetes too well. They say, doctor, I don't think so. So you're sitting stuck now. How do you convince this person that there has been poor control for the last 3 months? HbA1c. So if the HbA1c is high, you can say, but listen, you've been poorly controlled for the last 3 months. That's why when you got an infection, you slip through into a decay coma. Now, that HbA1c is very accurate in telling me what's been happening on average over the last 3 months. Here, it just tells you it may be happening, and that's the problem with this test. So the functional test, which is the me screen, tells you what is happening right now. And these were the limitations, but you'll see that they no longer limitations. So limited access through academic and scientific centers, mainly for academic studies. But now it's available to you. It's invasive, yes. It's not like a breath test or a BP machine test, but so are these. That's a biopsy, and that you have to collect blood. Okay, you have to collect urine, but one aspect of it, so it's not invasive. But the urine test on its own doesn't help, so you still need the blood test. So here, it's a finger prick. And yes, the cost is high, but that's because currently the client is paying for it. That is also an expensive test, which is currently carried by governments or by medical aids. And these are not covered by anybody, so it's also expensive. So from that perspective, generally these tests are expensive. So in summary, genetic testing is effective in establishing primary mitochondrial disease. Genetic testing results on having a gene associated with the condition, but does not mean one will get the disease, but will help stratify and a strategic plan in terms of what you're going to do for this individual. Genetic testing, like biomarker testing, has a high interpersonal variability and is influenced by many factors outside of the disease, making it difficult to use as a single marker to diagnose mitochondrial disease, whether primary or secondary. Biomarkers have high interpersonal variability and can be influence factors outside, such as diet, exercise, environmental stresses, will make the interpretation of these tests a bit more difficult. Functional testing can provide a new data set that provides specificity in degradation, in function, and can help better understand the cause of one's condition and guide the medical intervention. Functional testing until recently have been limited to fund research, but now has become available to you and I. These are the publications that support the slides that just went through. And now a short few slides in terms of if you are going to be using this in your practice, how do you explain it to your client? So me screen. Describe the me screen process of collection through results, understanding the measure report, the measure reported in the screen panel. We're going to go through an example of a report and review the relevance of this in clinical practice. So these things are available online. That's the logo, me screen. Me screen is a mitochondrial efficiency, hence ME screen, that measures mitochondrial function, structure, efficiency, which is directly linked to wellness and disease. The test is performed with a simple finger prick in the comfort of the client's home or in a clinician's office, and can be performed by a clinician or supervised by a clinician or somebody that helps in your practice. 4 to 6 drops of blood go onto a blood collection card, so it's a little square card, super absorbent with 2 wells, and you need 4 to 6 drops in each, and let it dry, air dry for 60 minutes, and then it can be sent to the lab. Basically in South Africa, it gets collated by courier and then gets sent off. In about 2 weeks, this is for Americans, so don't get too excited. Ours is taking about 3 or 4 weeks. So in about 2 to 3 weeks time, results are made available to clinicians who can then schedule a follow-up to review the patients. So for people like in the non-medical fields, the dietitians, homeopaths, doctors, pharmacists, everybody can do these tests. Personally, I just call the client with the results and give it to them over the phone. But you can basically call the client in, and you're going to see it's quite an extensive report. So establishing a baseline knee screen score provides a clinician and patient a measure to compare against future assessment to assess if the healthcare protocols, be it supplements, be it lifestyle changes, be it medications, have had the intended impact. You've got a patient who's got diabetes, there's an HbA1c, you do an intervention, diet, exercise, start 1 or 2 drugs or an injectable. 3 months later, you look at the client, the HbA1c's come down from 8.2 to 7.1, we're doing good. Client's got blood pressure problems, you tell them, listen, your blood pressure is high, 160 over 85, go and do some exercises, watch your salt intake, you come back, sometime later, you measure the blood pressure, it's worked fine. If it hasn't, you give them treatment, and then you measure it again. So like that, this tool can be used. Mitochondrial health and function can change with diet, sleep, mental well-being, supplementation, and medication and other approaches. How do you explain the screen to them? So it's a multi-dimensional mitochondrial efficiency screen that measures 11 core functions and structures of the mitochondria. It provides a detailed analysis of the energetics and structural profile. The measure includes energy production, so how efficiently are your cells producing energy in the resting state and in the stress state. Stress doesn't mean I'm worried. It can mean running, jogging, or just doing work. So it's resting as opposed to non-resting state. The ratio of how your body produces energy, whether it's from glycolysis or from the mitochondria, the spare capacity that exists within your cell and that can be called upon to react to stress. So in case you need to run away from a lion, how much energy can you call upon your system to do that? The structure and mitochondrial networks provide insights into how well or structurally dysfunctional mitochondrial are. Most diseases will impact mitochondrial structures and networks. We look at ROS, reactive oxygen species, which is an indicator of free radical production. Free radicals will cause inflammation, injure cells, and basically cause aging. So you will see that this is vitally important, right? So instead of going for blood, urine tests that were done and that are not as accurate, knee screen allows you and tells you what is happening in your client right now. The sample, which is a card that is holding the blood that is dry, is stable for up to 2 months. So certain factors, so the factors that I'm going to mention up on the other tests will not affect these tests. The results are minimally impacted by day of time, whether you eaten or not eaten, and other conditions that will routinely affect blood, urine, and other testing. So your old-fashioned blood, urine, and genetic testing has many things that affect it. Certainly blood and urine is dependent on time of taken, whether you've eaten, whether you've exercised, the amount of time the sample remained at the venue or at the lab. All of these basically affect it, whereas this one is quite stable. So you want to try and convince your client why they should be doing it. Like I said, establish a baseline ME screen score provides you with a measure to compare against future assessments. It is a new vital sign to track, like blood pressure, like pulse, like HbA1c, like oxygen saturation rate, like your VO2 max. It can be used by a clinician to assess if your health protocols, everything I've mentioned, are having an intended impact. Mitochondrial health, and we spoke about it in module 1 and 2, except for the red blood cell, every organ, every tissue in your body has mitochondria, and that is the battery for that cell. So mitochondrial health and function can change with approaches related to diet, sleep, mental well-being, supplementation, hormonal changes, hormonal replacement therapies, and other approaches. And these changes can be tracked and detected using mitochondrial function. Imbalances in energy production, capacity, ratios of how energies are produced, how free radical production is, and how it impacts disease. So basically, this is another data set that can validate or confirm why patients are feeling in a certain way. Conditions like Parkinson's, Alzheimer's, neurodegenerative conditions, memory issues, clients around the spectrum, all have a hallmark pattern in high free radical production, an increase in reactive oxygen species, whether they're in a rested state or in a stress active state. Mismatch energy production, that is high glycolytic to mitochondrial energy production. This mismatch can be seen in many conditions and makes the hallmark of fatigue syndromes, long COVID, and many other conditions, which we touched on. So this is where the 4 modules end. I'm going to just creep back to what I discussed in module 1 and 2 and just show you how you and I in the medical field are so, I think brainwash is too strong a word, but basically we only do what medications provided by pharmaceutical companies will achieve for us. Whereas sometimes some of the simplest changes can have a profound effect. So for module 1 and 2, I gave away my age a bit, where I said, in my days as a medical student, and certainly when I was at Barra, we used to get cases of beriberi, which is a case where the patient comes in frank cardiac failure, acidosis, on the verge of dying, and we thought our mentors were like magicians, because they would recognize it like this, and Prof. Dub would take some thymine and just inject it into the drip, and it was like magic. Within 24 hours, the cardiac failure is completely resolved, acidosis is gone, the sweating, the fatigue, everything is gone. And what was the treatment? Thymine. And so in beriberi, it tells you the importance of thymine and what's happening with NAD to NAD+. So the Krebs cycle is where energy is made. This is the basic way it looks. We mentioned succinate earlier in the talk, citrate, fumarate. So these can be considered as waste products that come out of the cycle. Now, what drives it? You got to look at the importance of NAD, which we touched on, and FADH, and basically here it's a donation of an electron, but that's what drives this pathway. What about the importance of vitamins? We don't give enough credence to the importance of vitamins. So I just give you an example of thymine. But there's niacin, there's magnesium, iron, copper, water, magnesium. What about trace elements and minerals? So can you see how this cycle is becoming a bit more complicated? But look at every level, the importance of factors, cofactors, enzymes, vitamins, minerals, and the end result is all of this is happening so that you can produce ATP energy. So don't take for granted the importance of this. Now, we've always known that mitochondrial diseases are important. We only thought there's primary mitochondriopathies, which are genetic conditions, and after fluency tests and this and that, and whatever, the neurologist gives them thymine. However, there could be many other interventions. I mean, look, you could have a problem here. You could have a problem with iron. You could have a problem with B5. You could have a problem with B2. And so how do you know where the problem lies? So how what's involved in mitochondrial repair or therapy? Water, very important. So just like your car needs water, because if the water levels in your car goes down, then there's going to be an overproduction of heat, and the engine's going to be, no, not overproduction. There is always heat production, but you're not going to be able to sort that out. And the water is very important, and so is the radiator. Just like that, our system needs water as well. Sleep, vitally important. And so sleeping before 10, having at least 7 to 8 hours, making sure it's not interrupted. That circadian rhythm, that rest is very important for the mitochondria. Movement, exercise. So we've all had a period where we were training a lot for 4 or 5 months, we become fit, and then shit hits the fan, and for 2 or 3 months we stop exercising, and then when we try and get back, we find it's not as easy to do the 100 push-ups as it was 3 or 4 months ago when you were at your peak health. So that just shows you a change in movement, how it affects muscle function, and what drives muscle function? Mitochondria and the density of the mitochondria. And so Usain Bolt wasn't born Usain Bolt. He had the potential of VO2 max, but he had to train, and he had to get those white fibers to start working, and Mark Pleikes had to get the red fibers working and increase the mitochondrial density so that they can perform as athletes. Hormonal balance, very important. In fact, just this week I saw a patient with primary mitochondriopathies, and the doctors then just take for granted that it's a mitochondriopathy, we're just going to have to live with it and manage this guy's diabetes as best as we can, and throw some thiamine and hope for the best. But there were multiple hormonal issues. The DHA and cortisol levels were affected. The testosterone in this 34-year-old was low. There was conversion of testosterone to estrogen. Homocysteine was out. Vitamin D was not measurable. It's the lowest number I've ever seen in my life. So I'm just giving you an example that for mitochondrial health, hormones have to be well balanced as well. So whether it's thyroid, adrenal, sex steroids, whatever, those are important. And here's the shocker. These are all the things that can affect mitochondrial dysfunction. And yet your patient begs you for NAD infusions, which are all the rage, and it's expensive. But if you don't have a before test, how do you choose what you're going to be treating the client with? I showed you the Krebs cycle and where the deficiencies may be. And then how do you have an after test to tell your client, listen, this thing is not working, I need to up the dose. So actually it's working, carry on. Because the treatment is not being paid by the medical aid. And some of these are expensive, and certainly you can't put a patient just for one condition on 16 things. So does coenzyme Q10 work? Yes, if that was deficient. Alpha lipoic acid? Yes. Carnitine, PQQ, NAD, infusions or injectables, oral, poorly absorbed. But what's the precursor to that? Nicotinamide, riboside, nicotinamide, mononucleotide. I'm told SAPCRA is going to put restrictions on this in South Africa because they don't understand it. You can take this thing sublingually. Niacinamide. Trace elements, very important. Methylene blue. It bypasses the system and directly donates energy. And so from that perspective, it's an alternative electron carrier. Red light therapy, certain frequencies. Spermidine, iron, B2, B3, methylene blue. Shit, okay, methylene 2 came twice. Okay, 15 things you could be doing. So what kind of a report are you going to be getting from San Diego if you send a patient for your mitochondrial test? So the first page is going to have energy profile. It's looking at the energy profile that assess the fundamental function of the mitochondria, because that's the energy factory, right? And so it looks at baseline respiration. So this measures how much energy your mitochondria is producing when you're at rest, like now, or more like you guys. I'm at least talking now, but you guys are just at rest, right? Which is good, and acting as your baseline energy production. What about the mitochondrial efficiency aspect? So this measures the energy your mitochondria loses when they are not active or under stress. So basically here it's like background loss. You're having a proton loss. That means you're not even doing anything, but you're just losing some energy. So my house, we've got central heating, but I've got lots of window. So I'm passively losing energy through the windows, right? And so we've got the same analogy here. Mitochondrial potential. This measures the extra energy capacity your mitochondria have when they are pushed to the limit. So all of a sudden, if you had to race against Usain Bolt, what can you ask your body to produce? So that's your potential at rest. This is what you're losing, what you shouldn't lose. And this is what can you summon up when the need arises. And so they divide your score like this. It goes optimal, 0 to 65, 65 to 100 is high, and they give it to you basically as this. And then there's a score, and then you saw on that app earlier where it gives you the score, and I'm told that in the next 2 weeks the scoring system is going to change, and then you're just going to get an overall score as well. So you get individual scores, but you get an overall score as well. So what about energy balance? So the energy balance panel explores the two additional components of mitochondrial health. So this is looking at glycolysis energy and mitochondrial energy, the balance between the two. So the glycolysis energy score measures the ability to generate energy without oxygen, anaerobic respiration. It is generally a less efficient way of making energy, but an important source under certain conditions. If this process is not efficient, you may feel tired and have brain fog and experience muscle soreness, especially after exercise. And I'm sure if you measure the client here, the lactate levels will be high and pyruvate as well. The mitochondrial energy score, a measure of how well your cells respond to stress and physical activity, showing the body's adaptability and recovery capacity. And then you look at the ratio between the above two. And that looks like this. So just mitochondrial energy, just glycolysis energy, and then the ratio between the two. The third part of the test looks at the mitochondrial reactive oxygen species. So to survive, we will produce ROS. The ROS score gives a more detailed picture on how your mitochondria's ability to create and handle cellular stress, especially in terms of ROS production. The reactive oxygen species production, this is when your mitochondria are stressed, they might produce more ROS, which can then damage your cells, membranes, your cell lipids, your proteins, your DNA. This damage is known as oxidative stress and can lead to aging, neurodegenerative disease, cardiac issues, cancers, diabetes, inflammatory conditions. So here you look at your baseline ROS, so measures the basal reactive species generated at rest. So while I'm resting, how much of this waste am I producing? And then when I'm stressed and running or working, how much am I producing? And looking at that balance. Remember, some ROS is important because it will help you then generate, if you exercise enough or push that muscle to increase your density of mitochondria. But then too much, when your body cannot mop it up, will cause damage. And so this is again expressed as like a speedometer, which is easy for a client to see then, you see. So we're also making some recommendation. So you're not left to your own device. So for this particular client, they suggested phosphatidylcholine and phosphatidylserine to begin daily support for membrane integrity. High doses of omega-3s, 1.5 to 2 grams, to buffer the membrane fluidity and reduce the network fragmentation. We covered that in module 2, the relationship between mitochondria and ER, which is endoplasmic reticulum. Lipid-friendly diet, so emphasize avocado, pastured eggs, sardines, olive oil, and get rid of trans fatty acids and seed oil, and then give you a mixed vitamin E cocktail, and that will help the mitochondrial membrane and prevent lipid oxidation. So this was basically to rebuild the mitochondrial membrane. You do that for about 3 months. After that, once you build the membranes, you can then continue lipid therapy, but then add PQQ or urolithin A, and this is going to help the remodeling of the structure. You can start doing restricted eating, a 12 to 12 hour, so that you reduce metabolic stress, you rest the mitochondria, get them to work. Movement patterns, so gentle training, yoga, breathwork, balancing of the parasympathetic, sympathetic pathways. And then you can talk about glutathione maintenance using NAC, selenium, sulfur-rich cruciferous vegetables, phenol-rich plants, cocoa, berry, rosemary, green tea, mitohomenesis. This is gradually introducing light stresses to the body, like sauna or cold exposure, so jumping in those ice baths in the gym, fasting, lifestyle changes, sleeping better, checking blood regulation, light exposure, especially early. The earlier you can look at the sunrise, it sets basically through red light therapy, sets the circadian rhythm, and that's been well studied. And this is just their suggestion, right? I gave you a whole list of things you could be doing. This one, I developed my own panel. So I basically took this, okay, these three parameters, these two parameters, and then broke it down into baseline respiration. And so whether it's coenzyme Q10, alpha lipoic acid, NAD precursors, or PQQ, and each one is doing something. So this guy is stimulating more mitochondrial production. This is promoting oxidative phosphorylation. This helps regenerate antioxidants, support mitochondrial enzymes, and you need coenzyme Q10. You saw it in the pathway for ATP production along the electron transport chain and so forth. And so to improve the efficiency, again, you saw a lot of these. We spoke about L-carnitine for the membrane, D-ribose, berberine, it's an MK activator and improves mitochondrial function, creatinine, rhodiola, an adaptogen, cordyceps, a combination of these to improve glycolytic score, because there's anaerobic respiration. I spoke to you about the importance of thiamine in beriberi. So you get out of anaerobic respiration and you move straight into producing 36 ATPs instead of 2. And yeah, so I'm going to leave it there. The MA screen is available. You can download the app. You can directly order the tests as a practitioner, as a GP, as a specialist, cardiologist, pulmonologist, psychiatrist, as a homeopath, as a pharmacist, people doing functional medicine, osteopaths, dietitians. So it's yet another tool in your armamentarium, whether you're managing weight loss and weight gain, to diabetes, to neurodegenerative conditions, to epilepsy. It's all there. You can order the test and then get your client to do it in your practice, and then you can collect them and somebody will come and pick it up and it can go off to the States, and basically we're pooling them. So once we get 10 in the country, we send it off. And mine, I told you guys, went off just before the last module. And or the client can go online themselves and make the payment, get it to their home, deliver to their home. They can do the test, send it off, and then come to you with the results. They'll obviously have to put you as the practitioner, so the report gets sent to you. The test is 7,500 rand, so it seems costly. But remember, this is a US test. It is only done in the University of San Diego. No other place on the planet can do the test at the moment. Of course, as the test becomes popular, maybe the price will come down. But remember, if you change it to dollar term, in the US, $320, $330 is nothing. We're finding it expensive because of our exchange rate. And for what this test gives you, I think it's a cheap test. A lot of us have done DNA tests. These things cost 6,500 rand, give you less information than this guy, and a bit more meaningful in terms of having a major clinical difference to your client. So for any questions, you can contact Nadine at mescreen.co.za. You will be getting CPD certificates. If you need me, you can contact me through my PA, Leonie, and these are her numbers, and we'll stop there. So, any questions? Stop sharing. Oh. All right. So I'm told by Leonie, she sent me a message that some of you guys never got a link. I apologize for that. Also said we're competing against a major launch, Vigami, tonight, and hopefully she'll make this available to you guys. Let's just look at the chat and see how useful are PQQ, NAD, and other supplements if patients use them sporadically and without doing any test. And you see, a good question, Nadia, and that's the thing. So if you, I'm coming back to diabetes because I'm an endocrinologist. So let's say you've got a patient with diabetes. Let's say you do an HbA1c and it's sitting at 10, and you convince the client, listen, you need glucophage. How do you know it's working? You have to do an HbA1c again. And so if you've had a reduction in 2 to 3 points on the HbA1c, you can tell your client it's working, carry on. Whereas if it comes back as 9.8, you're going to have to change your strategy. And so remember, in functional medicine, there's 3 major pillars. Hormones, a hormonal change, gut health, that's where Kim comes in for the live blood analysis, or you can set it off for stool analysis, and then you get the mitochondrial arm. Functional medicine doctors have always ignored that because you can't test for it. And if you can't test for it, you're going to have a before. And if the before only mattered because there's only one intervention, then it's okay. Give the intervention and hope for the best and just look at whether the patient's feeling clinically fine. You'll never know whether it's optimized or not, or you won't able to adjust the doses. Whereas with this test, you've got the exact before. It tells you where you need to intervene from those 15 odd different things, plus lifestyle, water, sleep, and then you've got a measurable test and say, right, this hasn't worked, I need to increase the dose, or instead of PQQ, let me do this. And that's why I've got my own treatment plan, but they're offering you a way of managing. So is PQQ useful? Yes. Is NAD useful? Yes. If used sporadically? No. And that's the point. And so from that perspective, yeah, I think it will be important. What is the profit margin for practitioners who order the test? I think it's 10%. I think it's 10%. Leonie will know more, and Benji is not online. But yeah, it's about 10%. So if it costs the client 7,500 for the handling fee, for the reading fee, and for managing it, of course, if you call the patient back in, you can charge him a consult, but it's 10%. Yeah, it's about 10%. I think it's no different to any DNA tests or whatever. I also did not get the link. Yeah, you're right. So, Alicia, I was just told by Leonie, that's why there's, I mean, the first module 1 and 2, we had 70 patients. So, not patients, sorry guys. We had about 70 people. So, there's no reason why they wouldn't have followed up on the 2, but I mean, it is what it is. We can't control that. I don't know who was supposed to send out the link. I'm just meant to deliver the talk. But I hope this was helpful, guys. Be brave. Don't be scared. There isn't a condition that I can think of where mitochondrial health is not important. And if this talk hasn't convinced you, these 4 modules haven't convinced you, just humor me. Just humor me. Go on to YouTube and type in longevity, mitochondrial health, or just mitochondria, or mitochondrial therapy, and the who's who of functional medicine will be talking to you online, and one of them will be the scientist who's uncovered this, Dr. Patel, and yeah, and I think at some point they're going to play that webinar between me and him, because he will better explain with passion why and how he developed this test and where it works. But there isn't a condition where this doesn't help. Somebody with cardiac failure, heart's a muscle, it's got mitochondria. Lungs, chronic disease, important. Liver pathology, important. Adrenal fatigue, vitally important. How many of us had a patient with an underactive thyroid? You get the TSH perfect, you do the T4, you do the T3, and they still tell you, I'm tired. What about your athletes? I mean, in terms of peak performance, this is where you need that extra energy. This is where you need to get and summon the last bit of ATP to finish that 100-meter sprint or the swim, or get through a 90-minute rugby match. So from that perspective, neurodegenerative conditions, yeah, from infertility to obesity, the mitochondria plays a very important role. So good luck, guys. If there's anything, WhatsApp me or WhatsApp Leonie, and she will pass me the questions. I hope it's been useful. And if some of you do the test and you're struggling to work out what the client needs from a treatment perspective, snapshot those results without the patient's name for the POPIA Act, send it to Leonie. I'm more than happy to give you advice in terms of what you should use in that particular client. But yeah, I hope this has been useful, and take care, guys, and good night.